Hi everyone, and thank you so much for joining this session. Thank you Tasneem for the introduction. And like she mentioned, I'm Dr. Lizahn Haasbroek, and I'm a product manager for our pharmacogenetics test. I'm a pharmacologist by training, and yeah, MediClinic Precise is, I'll give a little bit of an introduction as that, on that as well. So to set the scene, I'm sure the doctors among us won't miss this sort of description or this definition, but just to give everybody get everybody on the same page. An adverse event is an undesired occurrence that results from taking medication correctly. The event can either be a type A or a type B reaction, where a type A is predictable and dose-dependent most of the time, and it can be categorized into a mild, moderate, or a severe. So i.e. this is kind of a preventable adverse reaction or occurrence, and a type B reaction are usually completely unpredictable. So it's not associated with dose in any ways, and it can be due to multiple factors like the patient's tendency to experience an allergic reaction, etc. So any patient who has any sort of untoward effect or outcome observed with medical treatment is experiencing an adverse event, and this can include a wide range of symptoms that fall between the parameters of temporary harm up until as serious as death. So a paper was published, and they found that in the United States, it's over 250,000 patients will experience an adverse event in that treatment setting. So globally, it is estimated that nearly 10% of patients experience at least one adverse effect in their lifetime. It's sort of a predictive measure. And a systematic review actually found that an annual incidence of adverse events occur around 10%, and 50% of those adverse events were found to be preventable. So on the other side, patients as individuals may also experience variation in efficacy. So the patient population may experience efficacy variations. And a report was published that showed the percentage of the patient population for which a particular drug in a class is ineffective on average, as depicted by this infogram. And right at the top there you can see antidepressants, particularly your SSRIs, are around 38% ineffective. Another example is your asthma drugs at 40% ineffective, diabetic drugs, antiarrhythmic drugs, and right at the bottom are the cancer drugs that are found to be 75% ineffective in the patient population, which is very jarring in my opinion. So why do some medications work for others and for some not? And this is due to a multitude of factors, some of them being your lifestyle, like your diet, your weight, your age, the differences in gender, as well as your ethnic background. And then the one highlighted over there the one highlighted over here is our drug-gene interactions, and I'll elaborate a bit more about that later, but that is just important to understand that our underlying genetics actually also implicates our response to medications. So in a traditional approach to prescribing medications to our patients, a doctor might look at the clinical guidelines for a specific treatment area. They will investigate the pharmacokinetic and pharmacodynamics of a specific drug, so what that profile looks like, as well as potential side effects, as well as some drug-drug interactions, either new or existing in the patient's current clinical regimen. And off of those kind of building blocks, they decide which treatment is appropriate for their patient. And this kind of results in some benefits, some do not manner. So some patients may actually benefit from this approach, others might see no benefit, so there's maybe a lack of efficacy, and others might experience significant adverse effects. To give a more practical example of what you may see in your doctor rooms, a patient goes to a doctor room, they discuss their symptoms with the patient, and a diagnosis is made. Then the doctor will look at as I mentioned, the traditional prescription pathway and determine a medication that's appropriate for this patient. And when the patient takes this medication, either one of two scenarios occurs. In the one, a drug is effective, the doctor is happy, everybody is smiling, the patient has positive clinical outcomes. In another scenario, the drug may end up being ineffective and the patient is actually experiencing significant side effects. The patient will then return to the doctor and discuss their side effects or their discontent with the medication, and the doctor will look at another medication down on their list following this traditional decision pathway. So this cycle sort of continues, and this is sort of classified as a trial and error approach, where there is a delay in the time to clinical outcome because the patient is constantly being moved from medications, and it's also a negative experience for the patient going through all of this trial and error process. So we also can think about a patient perhaps losing that trust between a healthcare provider or just overall associating medication with this negative experience. So I actually want to introduce the concept of pharmacogenetics. Some of you may have heard the concept. So just again to get everybody on the same page, pharmacogenetic testing is the science, or pharmacogenetics is the science of how an individual's unique genetic profile can affect the pharmacology of certain medications. So within a population group, we are able to then identify which the medications work for certain individuals and may be less beneficial for other individuals. So it's mainly adding another step or tool in this prescription pathway that a clinician is already following. But adding this additional layer of information, they're able to make the best decision for their patient based on their genetic profile as well, and not just from the drug perspective. So again, visiting this patient journey pathway, the patient will visit the doctor and a diagnosis will be made. The doctor may then order a pharmacogenetics test, either because of previous side effects that the patient has experienced with a particular drug, and they decide to introduce pharmacogenetic testing. The doctor is then able, with that result, to prescribe the right medication at the optimal dose for this individual patient. So it's giving an individual approach to how patients are treated. So the outcome is the happy smiling doctor and the happy smiling patient, where there is a minimal risk of side effect and optimal efficacy. So not to bore you with the genetic technicality and jargon perhaps, a brief background in how this genetics sort of works is our DNA contains specific information that instructs the body to function, to produce certain proteins and transporters for it to function optimally and to do its daily tasks. But that also includes genes that code for specific enzymes as part of a metabolic pathway. And these metabolic pathways are responsible for drug metabolism, activation, and also efficacy. So for example, we obviously inherit a copy of a gene from each of our parents. So for instance, a patient inherits a gene that has lowered or decreased function from one parent and a normal gene from another parent. This may result in an altered drug response. So based on that genetic principle is how pharmacogenetics or a pharmacogenetic report is being produced. It's on those kind of building blocks. So what that looks like in a result format, a patient may be classified into one of 4 different metabolizer statuses. So on the far left over here, we have a patient that's classified as an ultra-rapid metabolizer. Now this patient is actually eliminating a drug at a much faster rate than the normal, and they might actually respond better to an increased dose of that medication, or they might need an entirely alternative medication altogether. Your normal metabolizer, as the name states, responds or metabolizes these medications at a normal rate, and usually the normal dose works pretty well for them. The intermediate and poor metabolizers have a decreased capacity to metabolize medications. And in the instance of an intermediate metabolizer, they actually need a reduced dosage to avoid any potential side effects that may arise from this toxic buildup of drug in their system because they're unable to eliminate it efficiently. And then the poor metabolizer also would probably respond better to a reduced dose or an alternative medication altogether, which is usually the case. So what does that actually mean? What does that classification, metabolizer status mean for a patient receiving a drug? So the science of pharmacogenetics actually has very key clinical evidence that is constantly reviewed, constantly updated, and collected in this sort of consortia or repository by the PharmGKB being one of the consortia or committees, and the CPIC being the other sort of research body. And what they do is they translate what a genetic result means from a genetic level into what that will look like for a drug, what that implication means for a drug. So in the instance of I want to use an example, but I'll rather stick to the list here. So the Pharmacogenetic Consortium will then set up these PGX dosing or pharmacogenetic dosing guidelines specific to medications. So just a few examples here of this gene-drug pair is your DPYD, which is a gene that encodes for an enzyme primarily metabolizing your fluorouracil anticancers. Another example is CYP2D6, which evidently encodes for the enzyme CYP2D6. You may be familiar with the CYP metabolizing enzymes, and they are largely associated with codeine and your antidepressants. CYP2C19, same is coding for the CYP2C19 enzyme, and they have a strong relationship with clopidogrel and as well as other antidepressants. And so forth. So basically, these consortia aim to keep evidence or classify evidence for a specific drug-gene relationship in which a doctor can trust that the evidence is good enough for them to implement this in a patient optimizing the patient's regimen. So there needs to be a specific level of evidence in order for these consortia to take those clinical recommendations into consideration. And it's also important not to be aware that not every and all drug that exists on the pharmaceutical market will be available in a pharmacogenetics report, and that's mainly due to the fact that that standard of evidence needs to be present. So there needs to be strong enough evidence in this kind of pharmacogenetics repository for that gene-drug interaction interpretation to be made possible. So just a very broad overview of what the testing workflow would look like. So the first section is more technical in terms of the data generation. We will collect a sample from the patient, and this is usually done non-invasive through either a buccal swab or a saliva test, although some blood sample collection methods do exist. The lab will then process that sample and generate a raw genetic data file. Then if we move over to the data interpretation part of the pathway, that genetic data will then be interpreted with a pharmacogenetics interpretation software, where the genetic result is now linked up to this repository of pharmacogenetic dosing guidelines in order to make those associations. And it's the clinically actionable recommendations are then presented in a report, which is then provided to the doctor or to the ordering party. So just to give you a bit more context into what that looks like in practice, knowing the whole testing workflow as well, in the instance where you have a patient coming in with acute severe pain after an injury, they are prescribed codeine, and then a week later the patient is complaining that they're not receiving any or observing any pain analgesic effect. So there's minimal relief. The doctor then decides, let's do a pharmacogenetics test. And the test result actually reveals that this patient is a poor metabolizer for the pathway that's responsible for activating the codeine into its active metabolite. So in this instance, the doctor is actually needs to prescribe an alternative medication, so a non-codeine medication. In another example of a patient with hypertension, they are receiving metoprolol. They are not receiving positive clinical outcomes, and the doctor is tired of this trial and error process. Now they order the pharmacogenetics test. And the test results reveal that they are an ultra-rapid metabolizer. And in this instant, an ultra-rapid metabolizer status will lead to treatment failure of this drug. So the guidelines suggest that this patient should actually receive 2.5 times the standard dose or given a completely alternative medication. And just to bring it back to the metabolizer status, what that definition means, the patient's actually metabolizing that drug too quickly for it to have therapeutic benefit. So that's why it might seem a little high to give a 2.5 times normal or standard dose to a patient. And then in the instance of a cholesterol medication that's being administered, in this case simvastatin, a middle-aged man is coming in for his routine checkup, and the doctor diagnoses the patient with dyslipidemia. The patient is put on simvastatin, and some time passes, and they complain of myopathy after starting this new medication. The doctor does a pharmacogenetics test, and they discover that the patient actually has a decreased function gene for the transporter that's responsible for utilizing this medication within the liver. And in this instant, the patient should actually be given a completely other alternative drug called pravastatin, for example, or the recommendation in the guidelines is to give a drug that's not as associated with that transporter pathway that will lead to a better clinical outcome. In terms of a depression case, the patient is struggling with their mental health. They're complaining about severe side effects from the medication, and there's just poor adherence to medication altogether. So after the doctor does the pharmacogenetics test, they discover the patient is a poor metabolizer for the drug that was given, which is amitriptyline, for that pathway that's responsible for metabolizing that drug. And actually this may lead to an increased plasma concentration within the patient, which explains their significant side effects. So in this case, the guidelines actually recommend that the doctor avoids using this medication for this patient, or to give a 50% dose reduction for this patient, and in addition to that, do some therapeutic drug monitoring to still make sure that there is optimal treatment, therapeutic levels present in that patient's system. So all of these examples are actually examples of a testing method or a testing methodology called reactive testing. So there are two models that exist, the one being reactive, where it's only after trial and error or significant side effects occur, or a patient is just generally unhappy with their treatment, where a doctor will inquire or order a pharmacogenetics test. The other instance, which is sort of the end goal of pharmacogenetics as a whole, where every person has a pharmacogenetics test done up front, and that's called preemptive testing. So before any diagnosis is even made or there's any disease present in a patient, you've already had your pharmacogenetics test done. When a disease arises, you're able to tell your doctor, look, I've had this test done. This is the information that you need to be aware of for me as an individual. So that's our ultimate goal. So this introduces a new treatment paradigm where it's more towards an informed prescribing method. And in this instant, like I just explained, a doctor will take that personalized information and stratify their patients into the specific, or tailor their medication to achieve specific outcomes. And in this instance, every patient benefits from that individual treatment approach. The main benefits of pharmacogenetic testing, of course, are the personalized therapy, where there is an informed prescribing approach. So the therapy is tailored to each patient as an individual. The maximum efficacy of their regimens are ensured in that optimizing approach, and the patient is expected to have minimal side effects in that instance, and the goal is to find medications that works for them as individuals, and of course a reduction in adverse drug reaction, as not everybody responds the same to every medication, and the goal is to limit potential side effects and improve compliance. The patient is still at the center of this journey, as we want to keep them maintain their trust in their physician, and obviously keep them at a high compliance with their treatment regimen. So there has been some publications recently about the utility of pharmacogenetics testing, the evidence found in this field. And there's a study that was published in The Lancet where they were called the PREPARE study recently, last year in February 2023. It was an open label crossover multi-centered study with nearly 7,000 participants. And what they found was that by doing a 12-gene pharmacogenetic panel to investigate the prevention of adverse drug reactions in 7 European countries, they found that an actionable result was found in 22% of participants. And an actionable result actually means that there was at least one variant identified in a patient that has a pharmacogenetic dose adjustment recommendation. So the evidence existed for that patient on that medication that they were given. And then they also found that a significant reduction in the incidence of an adverse drug reaction by at least 30%, or by approximately 30%. So they concluded with the thought that large-scale implementation could absolutely help to make drug therapy increasingly safe. And it's evident through that 30% reduced risk. So to come back to the thought of precision prescribing and what that journey would look like, if a patient comes in to the doctor's office, they will be prescribed a pharmacogenetics test. Then there's the lab component, what the doctor sort of isn't involved in. That's where the pharmacogenetic analysis occurs. What they will receive is the test result in the form of a report, and together with the patient, they can then develop a personal treatment strategy and optimal doses for their treatment. So the ideal candidates in this scenario of pharmacogenetic testing are your patients that have acute or chronic pain, patients that suffer from hypertension and dyslipidemia, patients that suffer from mental health like depression and anxiety, gastrointestinal issues like GERDs, as well as key candidates being your polypharmacy patients. So we do acknowledge that there are significant challenges moving pharmacogenetic testing into practice, and one of them being your time as a doctor is very limited. You have your 15 minutes with your patient, and you need to assess them and give them a treatment regimen in that small window of time. So we are very much aware of the lack of time for you to learn a new language, learn a new system or an interface or a platform, as well as the pressure that you have sitting with the patient across from you, now thinking about what do you do with this pharmacogenetic recommendations that you don't know how to implement in your patient's regimen. So we also are aware of the feeling that doctors might have that we are taking away the prescriber autonomy. That's absolutely not the case. Pharmacogenetics is an additional tool, like I mentioned, in your tool belt. So the doctor is still the person that makes the final decision on treatment, keeping all of this personalized genetic information into consideration. And with that being said, there might still be a very good reason why a doctor may still use a drug that perhaps has a red flag in their pharmacogenetic report to still prescribe that drug due to other factors that are present in the patient's full clinical context. So they still look at the patient as a whole with this additional puzzle piece as almost like a filter on how to tailor their medication journey. In terms of medical aid coverage, that's a question that always comes up. There is limited coverage, but we are constantly engaging with medical aids to get these tests reimbursed, even if it's at least partially, because we're aware that we don't want to only service a very small segment of the population, perhaps. And then also another very relevant conversation that comes up is the relevance of these testing methods on our African and mixed populations locally in South Africa. And that's something that is certainly always top of mind and is continuously being researched. So the limiting factor being research in this instance in the pharmacogenetic scientific field is we need to really take hands as a provider company and doctors or medical professionals to see how we can engage better and engage these funders and engage research institutions on how we can collaborate to push the needle essentially on the research done on African and mixed populations to make it as relevant as possible for them as well. So a brief introduction to Mediclinic Precise. We are a bundle of DNA-based diagnostic and clinical interpretation services. We're offering a new approach to healthcare based on an individual's genetic profile in order to customize their wellness, their disease prevention, and health management plan. And we have a diverse integrated team, and as well as the consultation portion of genetic testing. So we have access to genetic counselors, and I'll maybe just introduce the team very briefly. So like I said, we're a diverse, integrated team. We are also able to counsel the doctor and the patient pre and post test on selecting the right genetic test for their patients, giving them guidance, and really holding their hand through the whole process with regards to counseling, pre and post test counseling, like I mentioned. So the Mediclinic Precise pharmacogenetic test is really a differentiator in this field, and the reason for that is we are only accessible through a healthcare provider. So it's the doctor that needs to order the test for their patient. And the reason for that being is to offer information and clinical results in a more controlled and responsible manner. So we don't want patients changing their regimen or jumping off of their medications once they see a high risk, for example, result for one of the medications they might be taking. And for that reason, we offer the results we send the results to the doctor, and in the end, like I've mentioned, the doctor is the person making the final decision on how to adjust this patient's treatment regimen. We offer pre and post test support, like I mentioned as well, for the doctor specifically. If they have a patient that they perhaps identified that can benefit from the test, we want to manage that expectation for the doctor too, because sometimes there may be a medication that they're interested in, but it's not covered by a pharmacogenetics test. And for the reason being of the lack of evidence perhaps for that specific medication, there just isn't any clinically actionable guidelines for that drug yet. A post-test consultation is also available for the doctor specifically between Mediclinic Precise and them if they have any additional questions or they don't know how to interpret the results specifically. And then also our reporting on actionable test results only. So we will only provide test results that have a clinically actionable test result, for example, a dose adjustment or an alternative medication that's recommended, etc. Because like I mentioned, not all and every drug are included in a pharmacogenetic test, and some might only indicate, you're at the risk of experiencing a side effect or not. We want to provide the clinician with precise, concise information on how they need to tailor the patient's regimen. And on that point, we also provide a summary of the results. So pharmacogenetic reporting usually comes out as a 60-plus page PDF report, and coming back to the doctor's limited time and just their sort of limited time that they see this patient, they don't want to spend that time paging through reports and finding the answer for the clinical question that they asked in the first place. So we interpret the full PDF report. We give a concise summary that addresses that key clinical question. Perhaps it was for, can I give my patient this antidepressant? We will give an interpretation and a summary on that therapeutic area specifically. And I'll briefly show you an example of what that summary report will look like. This is a patient that is experiencing hypertension, so they went to their doctor to find out if what they are taking is actually correct for them and optimized for them. And in this instance, you can see hypertension was the diagnosis. The patient is currently taking Lizahn and some omeprazole for acid reflux. The results actually came back as normal. So the patient is a normal metabolizer for the pathways involved in these, the metabolism of these drugs. So that doesn't mean it's a negative result. It just means that the doctor can now be confident in the treatment of this patient. So should any other problems arise, they know that it is most likely not due to the metabolism of this medication in the patient's regimen. So it's also important to consider that obviously not pharmacogenetics is not the only reason why there may be a specific reaction or a specific lack of efficacy. There's many other factors that I mentioned in the beginning that also has an implication on efficacy and the appearance of adverse effects. So this patient's summary was that there's no further recommendation to the current treatment. The patient has a normal metabolizer status that's involved in these drug pathways. In other words, you can expect a normal response. And then we also give a summary of the pharmacogenetic implication of cardiovascular disease as a treatment area, so that if there's a future diagnosis that arises, for instance, the patient needs to be put on... Ooh, I went too fast. I'm sorry, let me just use the pointer. The patient possibly needs to be put on metoprolol. This individual is actually an ultra-rapid metabolizer, so that already includes some pharmacogenetic guidance on future treatments as well. And it's also important to remember that this is almost a once-in-a-lifetime test. So if there is a new diagnosis that arises in a completely different treatment area, the doctor is welcome to contact us to request this new pharmacogenetic report for this new diagnosis. Let's say it's chronic pain, for example. So we're able to re-look at the original data and give a report on that as well. And it's at no additional cost. So we can have that interpretation as well as the consultation with the doctor again. So if you wish to inquire a bit more about our pharmacogenetic test as well as our other product offerings, you're welcome to visit our website, or you can email the email address over here. And we do offer a number of channels to patients and medical practitioners to obtain detailed test information. So yeah, you're welcome to visit our website. We have a stand. It's in the second row on your right, stand number C11. If you want to come chat to us over there, we'd be happy to talk more. And thank you very much. Thank you for your attention.
Thank you.
Do we need this for the next speaker?
What is the price for a test like that?
Okay.
Lizahn, we have a question.
Of course, we're doing questions. I'm sorry.
Question over there.
Of course.
The price of the...
Can I talk here? Cool. Sorry, I missed that.
Wants to know the price of the test.
So we're offering the test at 4250, so just under 4,500. And while it might sound alarming, it is a full inclusive package. So that pre-test consult that I spoke about, post-test consult, that's included in the price, as well as the kit, of course, the sampling kit. And yeah, it's really, we've done our sort of market research, and it's kind of in line with what else is out there.
Thank you. Tell me, is there a list of drugs available that are affected by this?
Absolutely.
enzyme.
On our website, you're able to find I think it's around about 215 odd drugs that you'll be able to look through a list there.
Thank you.
Yes.
Thank you. Thank you for the presentation.
Thank you.
Yes. Just thinking of the cost implications, well, for a practice, maybe for a GP practice, how would you approach a patient who you think would benefit from this? For instance, you are trying to be as cost effective as possible. You are consulting with this patient, and then let's say, for instance, the patient is coming up with some whatever pain that the patient has, then you prescribing whatever codeine and so on, and along the way you pick up that it's not working. So is it a question of you first checking if the patient is not responding, or would you go ahead and go for the test even before the patient presents whichever way?
So on your first part, I mean, this is our launch week officially, so we're very keen to hear feedback about doctors' experience with patients, especially in terms of the feasibility of the test. So one other thing that we're thinking about is implementing payment plans where patients can, like pay off a test over a certain time period. So that's all of the lessons that we'll certainly be learning as we go along. In terms of the when you introduce the test, did that answer your question? So in terms of introducing the test, it's all, I think it comes down to the clinical history of the patient, firstly, so the journey that they've already walked with you as a clinician. And then secondly, if there isn't any, let's say in terms of pain, like pain relief or the adjustment that you've made after doing this pharmacogenetic test, it's also important to investigate other factors that might be contributing to the lack of efficacy, essentially, or even the presentation of side effects. So that's the other side of the coin almost. Yeah, and also what I didn't mention in our example, there might be drug-drug interactions as well. So we are able to report on those too. So we'll give you very specific recommendations. And again, you as the clinician make the final sort of assessment and decision, but you'll be presented with all of that information to make that decision. Thank you.
Any other questions? I actually have a question. I'm not a prescribing practitioner, but I'm sure this will be interesting to others. You mentioned that there's a kit obviously included. So if practitioners want to implement this in their practice, would they need to have the kit beforehand, or would they have to contact you and request a kit?
So we are open to collaboration in that fashion. Currently, how it's offered is the doctor will order the test online. So you will go to Mediclinic Precise website and you will order the test for the patient. We then arrange for that courier or logistic services, so the patient will get the delivery of the kit. They can take it in the comfort of their own home. So that's the sort of one option, but ultimately the ideal is to make it as easy for the patient as possible. So if a doctor is willing to keep some of those stock on hand for a patient that they have previously already identified, if it's in the practical example of a patient that's coming for monthly or maybe not monthly, regular follow-ups, they already have that patient in mind. They can just prescribe the test when they're seeing them next. So that might certainly increase the accessibility of testing. So again, we're open to having those conversations for sure.
Thank you so much. As I said, I'm not a prescribing practitioner, but I work in the mental health space, and I'm just thinking in terms of psychiatrists, how many of my patients, are non-compliant with medication because of the adverse drug reactions. So I'm assuming in the chronic space, and to answer your question, I would imagine you would have to look at the opportunity cost. How much would you be saving your patient by giving them the right medication? Because chronic medication is expensive. And if you are paying out of pocket, you can rather get the correct one than waste money on the incorrect one. So thank you so much. That was very interesting. And just a token of our appreciation for your time and for sharing your knowledge.
Appreciate it.
Thank you.
Thank you